that is really same-day joint replacement and everything that just encompasses that. So, welcome. Thanks for joining us. So, tell us a little bit about yourself.
Yeah, so I'm actually a Wisconsin native. Grew up just south of Green Bay, Freedom, Wisconsin. I did all my training at the University of Wisconsin, Madison, undergrad, medical school, residency. And then I did a fellowship in hip and knee reconstruction at Colorado Joint Replacement in Denver. So that's where I really wrapped up my training, came back, and I've been here ever since.
Well, I know how much you love the outdoors, so I'm sure Colorado was a blast.
It was a blast.
So today's topic being same-day joint replacement.
Yeah.
So let's step back and talk about the main diagnosis people are coming to you with.
Sure. Is
arthritis.
Yeah.
So for those that really don't understand what it is, how do you explain what arthritis is?
It's a confusing term because oftentimes when we say that you have something, it means the presence of something inside of your joint or your body. However, with arthritis, what it really means is that you have the absence of cartilage inside of a joint that results in bone-on-bone contact. So cartilage doesn't have any nerve endings in it, but bone certainly does. And when you have bone-on-bone contact, that really drives forward the pain, stiffness, and disability that people experience with arthritis. So that's what arthritis is. And of course, there's a wide variety of arthritic severity, of course. People with mild and moderate disease may have very mild joint pain and have intermittent symptoms. But as the cartilage thins and more bone gets exposed and there's more bone-on-bone contact, people have greater severity of their symptoms, more pain, more stiffness, a decrease in the range of motion, and oftentimes then have functional troubles where they're not able to do what they want or need to do.
Right, so I'm a physical therapist. I've been treating for about 15 years.
Yeah.
And when we started, I heard docs all the time say, you really need to wait until you're like 70 knee replacements. We have no idea how long these are going to last.
Right.
That's evolved a lot, right?
It certainly is.
What is kind of that window? I mean, obviously, I know you'll do it a few, but what is kind of that window where you see your main demographic that you're seeing come in?
Yeah, I mean, the main group of people that I see are between the ages of 55 and 75 years of age. But quite honestly, it ranges really from people in their late 20s through people in their 90s, if I'm honest about it. And certainly we were concerned in the past about the longevity of total hip and total knee replacements, but as time has progressed, we've seen improved longevity, and with that, we've become more comfortable with opening up the conversation with people who are younger and younger, particularly as it relates to the upgrades in the plastics that we use.
Sure.
They are far more wear resistant now than they ever were before. They contain antioxidants which really stop the oxidative process that starts the domino effect that results in polyethylene wear, which really is what is the determinant of the longevity of the hip and knee replacement.
And they really do seem like they're lasting longer than we ever could have imagined.
There's no question about that. We're seeing that especially in hip replacements. It's even more accentuated in hip replacements than it is in knee replacements. Yeah.
So again, step back in my career 15 years ago,
Yep.
It was very common. People are staying 3 to 4 days in the hospital. That was just a given.
Absolutely.
I mean, my protocol more or less said post-op day 1, post-op day 2, 3 to 4, right? Like that was the jam. And one of the things, sadly we're getting through this pandemic here, one of the things on our end that it really forced our hand to figure out was the same-day joint replacement. So let's start with what was the biggest things you felt like had to be right for us to even be thinking about doing same-day joint replacement?
Yeah, let's take a couple of steps back from that for a second. So even before the pandemic, you're right. We had a number of things that we were doing in order to evaluate whether or not same-day discharge arthroplasty was reasonable. And frankly, over the course of the last 5 years, amongst surgeons like myself across the nation, we were evaluating various protocols, anesthesia, pain protocols, therapy protocols, to see whether or not this could be done safely first and efficiently. And there are plenty of centers across the nation that were doing so. Where I learned of this really was through the American Association of Hip and Knee Surgeons annual meeting in Dallas. It was in 2018. And after that meeting, when it really was apparent that we could do this safely, I really felt as though we needed to make that next step to do same-day discharge. Because for several years now, probably the last 7 to 8 years, it has been next-day discharge has been the standard of care.
Right.
But very few people have really delved into same-day discharge. The number of things, again, first, we have to go back to safety. We had to make sure that we could accomplish this safely. So number one, that people had to be evaluated in an appropriate time frame in the hospital by the physical therapist to ensure that they were independent with their mobility And that required us to get them upstairs, out of the operating room theater, and be ready to participate in that therapy. And the only way to really have that happen was to shorten the duration of the anesthesia that we provide. And so our standard prior to same-day discharge was using a medication called bupivacaine that would last for somewhere between 4 and 6 hours. And we used a new medication called mepivacaine that lasts for about 2 to 3 hours, sometimes shorter. And that allows for those individuals who have had surgery to be in recovery for a short period of time, be on the inpatient orthopedic floor for 45 minutes to an hour before they're really ready to participate fully in physical therapy. That gives our therapists the opportunity to see them, evaluate them, and say whether or not they're independently safe to go home that same day. That is a huge part of all of this. The other part about this is their pain control afterwards. I think a lot of people are concerned about being discharged at home the same day as their hip or knee replacement because of the pain that's associated with it. Over the course of the last 10 years, we have changed what we use dramatically as it relates to postoperative pain control for hip and knee replacements. So certainly using a spinal anesthesia as opposed to a general anesthesia provides improvements in terms of their pain. And then what really accelerates it is something called a periarticular injection. And that is a combination of medications that is put into the soft tissue surrounding the hip and the knee that allows for people to have excellent pain control for the first 12 to 24 hours. The difference between that periarticular injection in comparison to a nerve block is it doesn't really affect the muscle's ability to function. And so people can really stand, they can stand and ambulate pain-free, and yet they can function or fire their muscles appropriately to participate in therapy.
So safely get home.
And safely get home. Those are the two biggest parts of this, truthfully, as it relates to same-day discharge.
No, I would agree. I think the pain control piece to me has been the most dramatic improvement in the last, again, over the course of my career, how quickly people look ready. Like you said, safe, but also ready. Because I do think there's the people, I think the one most biggest misconceptions is we're rushing them out. We need to get you out the door. And we wouldn't if we thought it was safe for one, but I 100% agree with you. Not only the cocktail, if you will, that you use around the joint during surgery, but how quickly the hard meds are out of the system so that they're ready to move and they're more coherent and do it. It really truly has been amazing how well it's gone.
Absolutely. And so we're using the different spinal medication, but we're also not using IV opioid medications, which really makes a difference, like you said before, in terms of the confusion and them feeling as though they're not quite ready to walk and ambulate and participate in therapy. So that's a big part of it as well, is not using those opioid medications and using really over-the-counter medications to help keep their pain under control for that initial period afterwards.
Yeah, I would agree. Number one, pain-wise, you gotta be ready to go home. And then same thing, like you said, safely be able to show all the things you're gonna have to do at home, because we're not coming home with you, right?
You bet.
So all the things that you can do safely, you gotta be able to get out of bed, get out of your car, up and down a couple stairs, get to your house. We have to practice that before they leave the hospital, right? So being safe and able to pass that. But I'm right, if they're not ready to go home, we'll have them stay.
Absolutely, and so it is certainly not a requirement that they go home the same day. It is an option for them to go home the same day. And if people feel comfortable going home and they have the appropriate social support at home to do that safely, then we can do that. That's another piece of this that we haven't talked about yet, but we have to make sure that people have somebody with them at home. And as long as they have somebody that can stay with them for 72 hours around the clock and be there to check in on them after that, that is really another requirement to make sure that they're okay to be there.
Yeah, and I think that's been the other piece. So for you obviously don't know, maybe my mom's watching, but you did my mom's hip.
Yep.
She did wonderful, and I think that was the piece that I was most impressed with the way that your team handled things, was that it's not it would be nice if you had somebody here with you. It's, I'm not doing surgery unless you have someone here with you, that coach, that support group. When did you really start making that where that had to be, that you saw that was so important?
Right out of the gate. So that is something that was really pushed into my mind in a very firm way in my fellowship. In order to have people do well at home, they have to have the social support that they are to do well. The safety nets, so to speak, because the hospital isn't there for them anymore. They need somebody else to be there. Like you already mentioned this, Charlie, but the other part of this that is really critical is the pre-operative education of these individuals before they even get to their arthroplasty. That is so critical. And, so certainly same-day discharge is feasible, again, if we use the right anesthesia, if they have the appropriate pain control afterwards, they have the appropriate social support afterwards. But really, we're setting them up for success by educating them thoroughly before surgery. So as a part of our team, we have nurse navigators who walk them through that process. So for instance, if you were to come to see me about your hip, you have arthritic hip, you failed non-surgical management, you're a good candidate for surgery, we talk about surgery, I would then introduce you to one of our nurse navigators. And what they would do is then not just schedule the logistics surrounding surgery, but they're making sure that you have all the necessary components in order to succeed both before surgery, during surgery, and after surgery. And that is critical. And so if we get to that point where the nurse navigator comes in and they check all the boxes that this is going to be safe, then we can have a reassurance that once the day of surgery comes, we're not making a decision about whether or not they go home. They're already prepared.
Yeah.
They're ready to go home.
Right, no surprises.
Absolutely, no
I mean,
surprises.
when we've had people that don't come through, don't do any rehab with us prior, and that come to see you here at the first touch point, a lot of times you'll send them to us even for one visit of,
You bet.
just make sure they know how to do everything they're gonna have to do.
Absolutely.
I call that prehab, right? Of
You
just
bet.
we gotta at least get you doing the exercises you're gonna do right after, but also we should start trialing, hey, try transferring where you want to go a lot of weight through that leg, try getting it out of bed, start thinking about all the things that could be surprises on the back.
Absolutely. The prehab with our physical therapist is critical, and then also with our occupational therapist, just in case they need any durable medical equipment to help them get on their socks and shoes, get the grabbers if they, need to get things out of their reach. Having all of that squared away ahead of time is critical for them.
So who's all on your team? So you mentioned a little bit of the nurse navigator. Who all else makes up your entourage, if you will?
Yeah, for sure. So my right hand man is John Berge. He's a nurse practitioner that has been working with me since day one of my practice. Wonderful man. I trust him completely. And he and I have a practice that mirror one another. So he's with me in the operating room. He's with me in the clinic. He and I really started and continue to nourish this practice going forward. So John is my right hand man. I couldn't do this without him. And then we have several staff in the clinic that are, all of them are critical, but several of them have been with us forever. So one of our nurses, her name is Amanda Huber, has been with us again since day one. Knows our process inside and out, knows our preferences, knows our patient population extremely well. And she is the one who really coordinates clinic for us so much. And again, we couldn't do it without her. We have nurse navigators, and we have 3 of them. They are all wonderful. Rachel has been with us the longest. We have 2 new nurse navigators, Amanda and Trish. Both of them are getting near the ending of their training. They're doing wonderfully with their nurse navigation piece. But that is the next warm handoff. After I leave the room with a patient to potentially go forward with surgery, the nurse navigators are taking them under their wing and guiding them through the rest of the process. And getting them into the pre-operative surgical home or the prepare clinic, where they're seeing a physical therapist, an occupational therapist, they're seeing our medical specialists over there, making sure that from a medical standpoint, there's no further medical issue that needs to be optimized before going forward with surgery. And then we're talking about the day of surgery itself. In surgery, it is really, again, myself and John. We have, of course, all of our support staff at the hospital, the circulating nurses and the surgical technicians. Then we also have a dedicated surgical technician who works with just our team and my partner's team, Dr. Kleiss, and that is Kyle Fenlon. And again, he has been with us for such a long period of time and knows our process inside and out. It makes us very efficient and provides a level of safety in the operating room. It's wonderful.
And then the other piece, kind of from a communication and trust, also is you pull from quite a large area.
Yeah.
So while you're treating in Green Bay, you didn't start here, right? You came from the valley up.
Yeah.
And because of your history, people continue to follow you.
Yep.
One of the things, regardless of COVID, that makes it harder is people don't always want to travel.
For sure.
And one of the things that I always say, I hated COVID, it was awful, but it forced me, there's a couple things. We were awful at utilizing technology for telemedicine, right?
No question.
It absolutely forced our hand to do that. How has your team found use in that?
Yeah, you're absolutely right about COVID. I mean, there are a couple of silver linings with it. Not many, but there are a couple. And certainly telemedicine is one of them, right? We were forced into that fire pretty quickly and abruptly. Quite honestly, through COVID, we were able to maintain contact with people via telemedicine, and that was mostly through video visits. Telemedicine has progressed to include not just video visits, but also true telemedicine visits, where they are seen at a site where there's a nurse and there's actually a telemedicine camera, and almost like a robot of sorts, that's a monitor with a camera, and they can move various parts so they can show us a little bit more on physical exam. The nurses are actually trained by us in order to do the physical exam. We watch them remotely. So when we're talking about that level of telemedicine visit, it can be very effective. We do have a huge catchment that goes up into Upper Michigan, of course, and a lot of those individuals are 4, sometimes 5 hours away. And if they can shorten up their drive to an hour or two, come to a telemedicine site and then have a visit with us, that is a huge benefit to them, as opposed to driving the 4 to 5 hours down to Green Bay to get those same recommendations. At times, those people still do come down after the fact, but at least at that point, they have the reassurance of knowing that there is a need for a face-to-face conversation as opposed to something that can be provided remotely through a telemedicine visit. So we have myself doing video visits or telemedicine visits in Marinette. My partner, Dr. Kleiss, is actually licensed to practice in Michigan as well, so he is doing video visits up in Iron Mountain as well. We are increasing that offering as much as we can so that, again, people don't have to drive and it's more convenient for them. And obviously we're getting better with COVID as vaccines roll out and the case burden decreases in our state for sure. But there are still some people who would rather have a video visit as opposed to having a face-to-face encounter if they can really get the same value out of that visit. And so we still have some of those people who are doing that.
I agree with you. I don't think, COVID forced our hand. I think telemedicine is not going away. The idea of making things more convenient so that we don't lose track of people, more regular touches that also then financially cannot be as big of a burden as well long term is nice as well. We have a question here. So, is it beneficial to do prehab prior to a total joint, like a total knee drill?
There's no question, and the definitions of prehab are going to vary based upon who you're talking to and what the endpoints are. If you look at the literature regarding prehabilitation from their preoperative state to their postoperative state and comparing outcomes to those who don't do prehab, you have to do a pretty rigorous regimen of exercises for a number of weeks in order to achieve that level of improvement postoperatively. But I think that everybody actually benefits, like what you were saying before, with sitting down with a physical therapist, going through the exercises, familiarizing themselves with what they're going to be doing postoperatively, and then talking through their specifics. How many steps do you have going into your house? Are you able to get into your bed? Is it a little bit higher? Do you have a tub that you have to step into, or do you have a walk-in shower? What about your vehicle? Is it up high? Is it down low? I mean, having a conversation about those things can ease people's anxieties, and they can get some of that information on the front end. Again, being prepared as opposed to dealing with the issues afterwards is a huge game changer in terms of people's perception of how they do postoperatively.
Just easing their way. I would agree with that. I think it's more, my answer always to this, we're not taking months off the back end of your rehab. Like you're not going to get better 2 months early.
Right.
But it's just going to go so much easier. You're taking away surprises. You know what things are going to be. Less unpredictability. I completely agree. I think that's what it's all about.
Less anxiety about the episode of care. If we can get people to the point where they know it's going to happen ahead of time, then they do a much better job of focusing on what they need to focus on, as opposed to being distracted by those things that they don't know or don't understand. So giving them that level of education ahead of time is going to really translate into a better experience for them.
Yeah. And then any other questions? We miss anything else? So the last thing I had for you then is, so we talked about the same day, we've talked about the being prepared. What are people really looking at? Let's start with total hip. Yeah. What's your kind of MO talking with people of how long are they really looking after a total hip replacement? What is the rehab?
For the rehab afterwards?
Yeah, just what are they looking at feeling like they're getting back to life?
Yeah, absolutely. And so I'm glad you brought up total hip first, but total hips and total knees are obviously extremely different in terms of their experience afterwards. I'm oftentimes trying to put the brakes on people with total hip replacements. People come in with very significant pain and disability, and they oftentimes are telling me during their hospital stay for that 6 to 8 hours that they don't have pain, that they walk for the first time without having pain in several years, and that typically persists to a large degree even through the first couple of weeks after their rehab. And so I'm trying to slow them down because really they do have to allow the soft tissues to heal and the bone to grow into the implants afterwards. And we don't want their activity level to disrupt the biology of that occurring. And so I'm asking people to take it easy for the first couple of weeks after surgery. Oftentimes people are using an ambulatory aid for the first couple of days, oftentimes 5 to 7 days. After that, they're either getting rid of those crutches or a walker, going to a cane, or to nothing at all. Doing therapy by themselves twice a day, but then also seeing a therapist at least once a week until they feel like they're at a place where they can guide themselves, and that's usually somewhere around 6 to 8 weeks afterwards, it seems. I am really asking people to limit their activities, their more rigorous activities, for the first 6 weeks. And the reason is entirely biologic, like I said before. It's allowing the soft tissues to heal, letting the bone grow into the implant. It's not related to their pain, it's related to the biology of the healing underneath, what's happening on the surface. And after that 6-week mark, if they're really doing well, then I really allow them to cut loose and start to do more strengthening exercises, more rigorous activities. But at that point, people still have some amount of activity-related pain, meaning that if they go out and they walk, 3, 4, 5 miles, they may have some stiffness and some soreness, and they may use some over-the-counter medications for that, at least for the, these 6 to 12-week mark. But then after that 12 weeks, really, oftentimes people say they don't have pain anymore, they don't have activity-related pain, they're back to doing not just their daily activities, but also the recreational activities.
Yeah, I would agree. He's totally different.
Oh my gosh.
Completely different.
Yep.
So on the total knee side,
Yeah.
and I always tell people it's, although they're both weight-bearing joints, it's just different. It just is. You don't realize how much you can work around the hip a little bit, get more comfortable than you just can't with the knee. What are people looking like after a total knee as far as timeline?
Yeah, and so I really do expect that they get to the break-even point at about the 6-week mark post-operatively. By that, I mean that the pain that they experience at 6 weeks following their knee replacement is a little less than it was before their knee replacement. That's the average. There are people certainly who are far beyond that, where they feel like they have considerably less pain at 6 weeks, and there are some people who feel like, gosh, I'm still lagging behind where I was pre-operatively at 6 weeks. But the average is they're just beyond that break-even point at 6 weeks, and I tell them they are 50% healed at 6 weeks after surgery. They are not there. There's a lot more room for improvement. And I feel like I'm oftentimes coaching people in that situation because it's a month and a half after the joint replacement. They're wondering whether or not they're going to get much better, even though that we had that discussion ahead of time. It is going to improve. There's a lot more room for improvement after 6 weeks. 80% healed at 3 months out from surgery. The evidence really points to 95% of a patient's improvement will occur within the first 6 months after surgery, fully healed at a year. So in terms of what they can do, daily activities undoubtedly, even community ambulation, going back to the grocery store, going to church, those sorts of things, like 4 weeks, back to doing light duty work at work at 6 weeks, moderate duties at 8 weeks, and then more heavy or intense activities at 10 weeks after surgery. In terms of activity tolerance, people get to having more robust activity tolerance by 6 months after surgery.
And it's just a different ride, right? It just is.
Undoubtedly.
Having to get your range of motion back is not a fun ride, but it's a necessity. But these two surgeries are such game changers, though. It's amazing how long people will just be willing to suffer because they're afraid of having a surgery. I always joke, the people that are willing to tell their stories didn't have a good experience. They didn't do their rehab. They didn't finish everything.
Yeah.
And they can't wait to tell people how awful it was. It really is a great experience. I always tell people it's worth the work that you're going to put in for those first 4 to 12 weeks after. It's worth it. You're going to get so much of your life back.
The evidence shows it, right? When you look at the outcomes following a total hip or total knee arthroplasty, there are greater than 90% good or excellent outcomes after surgery when they are considered to be fully healed. You're changing people's lives. Instead of having constant pain and stiffness and disability that results in their inability to do what they want or need to do, they're now engaging back in the things that really they find fulfillment in, find joy in. Playing with their grandkids, going back to work, hiking, cycling, swimming. I mean, I see a lot. I even have a fair number of people who go back to running, frankly, specifically following a total hip replacement. So it undoubtedly is a game changer for people, but I understand that it's anxiety provoking. I mean, it's major surgery, it's invasive in many ways, and people have had people tell them various experiences before, but they really need to kind of get over that and just have a face-to-face conversation with their orthopedic surgeon and make that dive.
So kind of closing idea here as far as advice you give to people. many people are dealing with arthritis, right? It's not,
Yeah.
it's a very, very common thing. What is your rule of thumb for somebody who is on the fence of if it's time for them to engage someone like yourself or your partner, Dr. Kleiss, hip or knee? How long is too long to be dealing with what you know is arthritic pain in that joint?
Yeah, I'm glad you brought up Dr. Kleiss because really both Dr. Kleiss and myself have similar philosophies as it relates to joint replacements and how to help people make that decision. And that's the truth about it, is we're helping people make the decision. There's no have-tos here. This is a matter of a quality of their life. So when people have advanced arthritis, they fail the non-surgical treatment options, then the next question becomes, does your pain and the amount of disability that you have that you're going to need result in a poor quality of life? And that's only something that the patient can really answer. I can't answer it for them, their spouse, their loved ones can't answer it for them. It's truly a personal experience. Do you feel like you can do what you want and need to do effectively, or are you not able to do that? If you can manage your symptoms with non-surgical treatment, of course, it's less risky to just continue with non-surgical treatment, physical therapy, anti-inflammatory medications, etc. However, oftentimes those have a ceiling effect, and then we get to that point where people feel like they're between a rock and a hard spot. They tried the non-surgical treatment options, yet they still have considerable pain, disability, and a poor quality of life. So then, what should they do? Well, then the next, real natural option really seems to be go forward with the hip replacement or knee replacement.
And just because you have a consult doesn't mean you're signing up for
Absolutely not. No strings attached, and that's what I tell people. No strings attached here. If you're going to go and have a conversation with a joint replacement surgeon, it is a discussion about what your options are related to your joint, not just the surgical option, but also the non-surgical options as well.
All right, anything we missed? Anything you think of that you want to talk about that we didn't get a chance to?
Gosh, I mean, there are a lot of hot button issues as it relates to hip and knee arthroplasty. The same day discharge arthroplasty stuff is really hot off the press, obviously. And the other thing that I think we haven't talked about as it relates to same day discharge is the safety as it relates to people coming back into the hospital. Before we really launched the campaign of doing this in a widespread fashion in my practice and Dr. Kleiss' practice, we had a series of patients that we funneled through the process, but still kept them for one night. And we monitored whether or not we had the ability for them to be safely seen, safely evaluated, and be deemed appropriate for discharge. And we took that data and then we said, okay, it looks like this is appropriate, this is safe. Now let's start doing it in a limited number of people and follow their data post-operatively. We did exactly that. We had great help from one of our clinical neurospecialists on the floor. Her name is Corey Desart. So if you're out there, Corey, thank you so much for all the hard work you do. She followed the data for us, and we looked at that in a comprehensive fashion with the entire team, myself, Dr. Kleiss, our assistants, the therapists, on an outpatient, inpatient setting, with Corey, of course, and the inpatient team. And we saw that there was not an increase in the rate of people coming back into the hospital, complications, post-operative complications on the floor, etc. So we felt like we had vetted it by seeing the process through it in a piecemeal fashion, and then we started to look at people's outcomes in doing it in a limited fashion, and then after that opened it up to people who we felt were appropriate in that regard. And we've been very happy with the results that we're seeing. We have ongoing data collection by our joint replacement program coordinator, Dave Reinke, and we are looking at this data every single month, and we continue to see safe discharge of patients at the time of surgery, or on the day of surgery. It's about 70% at this point. Not everybody goes home. There's still 30% who stay, and of that 30% who do stay, it's oftentimes because they have surgery in the afternoon, and there's just not enough time for them to, see a therapist and then go home in an appropriate time frame. We're not sending people home late in the evening, of course. We want to be mindful of people's drive and getting them home safely in that regard as well. There are some people who are just better just to stay for a night, have a single night observation, make sure that from a medical standpoint there's nothing else that needs treatment or observation before they go.
Yeah, and I think too many times people think you're just trying to get me out to get another bed. There's no way we would be doing this if it wasn't safe. And honestly, I'd rather sleep in my own bed. I want to get home. I don't want to be at the hospital. not even about a pandemic. I don't want to be at the hospital. I want to be at the comfort of my home. This is really what this is all about.
And that's exactly what people are telling me. They're like, my gosh, it is so nice just to go home,
Yes.
sleep in my own bed. I hear people and their spouses saying after the fact, gosh, you know, I came in and had surgery in the morning, went home, and I was having dinner at my own dinner table that evening. You know, and they're shocked by it.
That's why
They're shocked by it. You know, and frankly, they're satisfied with the process. They're enjoying the process, and we're doing it safely. So I think it's a win-win for everybody.
Great. Well, thank you so much for joining us. That was awesome.
Of course.
If you didn't get to answer your question and you have more questions, please just leave them in the comments below. And again, thanks for watching.